Well, I see that we're starting the recording of this session, so I will go ahead and say welcome everyone to the monthly webinar presented by the Northwest Regional Telehealth Resource Center. I'm Bob Wolverton, Program Director of the Center, and I'll be the host, I guess, today. Before we get going with our speaker, let me take you through the Adobe Connect room just to be sure that we're all on the same page. Up here on the left, you will see a listing of the attendees. In the pod just below the attendee pod, you'll see a group of files that you can download. One is a save-the-date postcard for our upcoming conference in Seattle, and the other is the presentation, the slides of today's presentation from Mario. Down in the bottom right corner, you'll see links to our beautiful new website and to a SurveyMonkey survey that we ask you to fill out at the end of the presentation. The survey will be very helpful for us in arranging webinars, and very importantly, it will also give you an opportunity to tell us which webinars you'd like to see in the future. So please complete that, and in fact, to make it so that you kind of need to complete it, Martha has found a way of putting that up on your screen as the conference winds down today. So please let us know what you thought of today's presentation and what you'd see in the future. To the left of the link pod is a chat pod. This is a place that you can enter your questions about procedure and questions about technology and techniques, which you'll see all the way over on the right, some notes that ask you how to talk to you about how to use that. And then to the left, this is an important pod too. This is a question and answer pod. You can type questions in on the bottom row there, and the questions will then appear before Mario, and he'll be able to answer them. I understand that his presentation is kind of broken into three segments today, so if you have questions about a particular segment, he can deal with them at the end of that. And of course, we'll leave a little bit of time at the end of the whole presentation for question and answers in general. So there'll be plenty of opportunities to talk with Mario. I also want to remind you that next month we have a webinar from another of our national telehealth resource centers. This will be with Garrett Spargo, and he will be talking about selecting equipment for telehealth. And we remind you that we will be having a conference in Seattle in September, March 30th to April 1st. It's a 3-day event with some great educational tracks, and we will be offering CME again, although I don't think I'm supposed to say that until we actually have the CME approved, so pretend I didn't say that, please. Today's presentation comes from Mario Gutierrez, one of my colleagues in the TRCs. Mario is Executive Director of the Center for Connected Health Policy. Mario, who joined CCHP in May of 2010 as a Senior Policy Associate, brings more than 30 years of experience in California's nonprofit health and health philanthropy segments. Prior to joining CCHP, Mario served as a Program Director with the California Endowment for 12 years, and there he led several major healthcare initiatives, including their 10-year, $20 million investment in telehealth deployment throughout California. He's also served as the endowment's lead person for rural and agricultural worker health programs and policy. For that, he served 6 years as Senior Program Officer with the Sierra Health Foundation. And as a recognition of his achievements in health care, Mario received the prestigious 2007 Terrence Keenan National Leadership Award in Health Philanthropy. Mario currently serves on the board of directors of the California State Rural Health Association, which is a nonprofit, nonpartisan grassroots organization seeking to improve the health care of rural Californians and the quality and accessibility of health care that they receive. He also serves on the board of directors of Ocean, one of the nation's largest and most successful nonprofit health information networks. Ocean is nationally recognized for its innovative use of health IT to improve the integration and delivery of healthcare services across a wide variety of practices, and they emphasize safety net clinics, small practices, and critical access in rural hospitals. Mario also currently serves as chairman of the Rural Policy Research Institute Rural Human Services Advisory Panel. Boy, that's a bigger mouthful than Northwest Regional Telehealth Resource Center. And in that position, he provides agencies of the federal government with policy analysis and recommendations to promote livable rural communities. So with that, I'm going to quit talking and take it away, Mario. And don't forget. Had a little hiccup there. It looks to me like Mario went to unmute his mic and signed himself off. So May, if you've got your audio on, could you please ask him to rejoin us and we'll get going again. Okay, Mario, you might need to re-establish your microphone connection and then you can go ahead.
All right. Is that working now?
I hear you.
Great, great. That was very strange. Thanks for that great introduction, Bob. Just as soon as I was introduced, we lost connectivity, so there's some weird things going on in the world here. But it's a pleasure to be with you. Our presentation today is going to be focused primarily on the policy issues that affect the use of connected health and telehealth on a statewide basis, nationally, and also we'll talk a little bit about private policy and private sector decision making related to telehealth. Just a few words about us and who we're about. We are a nonprofit public interest organization, so anything that we say here today is purely for informational purposes. We don't provide legal advice, and of course we don't have any commercial interests, or we're not a membership organization. So yes, as Bob was saying, the Center for Connected Health Policy is one of the telehealth resource centers, and we have been in business since 2008 when we were created by the California Healthcare Foundation. And for the first 2 years of our activities, we focused primarily on reforming the laws in California related to telehealth. California passed the first comprehensive bill back in 1996, which was outdated. And so the Healthcare Foundation created our organization to do, among other things, take a deep look at the law and what needs to be changed. And that resulted in a bill. We proposed the model legislation, and the California State Rural Health Association was the author of that bill, or the sponsor, and we had bipartisan support, and the bill was passed within a year without a single vote of opposition. So it just goes to show that this whole area of telehealth and interest in the underserved, whether it's rural or in urban areas, is something that everybody can appreciate. And I think as we move down the road of looking at changes in policy, that there are ways of presenting the importance of telehealth that speaks to all policymakers and all politicians, and hopefully we'll be able to see changes in the future. This is a screenshot of our website. We're just now in the process of combining our two websites. We had a California website and our national website related to our grant that we received from HRSA to be the National Telehealth Policy Resource Center. But in essence, everything will, to the external public, will be the same. This website is available to you and anyone to go into questions related to telehealth policy, the legal issues, and we have specific information on different kinds of modalities of telehealth, where you could actually view videos and also have up-to-date news on the latest happenings in policy around the country. We maintain this website on a pretty regular basis, and one of the highlights of the website, which I'll talk a bit more as we get into this presentation, is our analysis of the 50 states Medicaid and other laws and regulations and administrative policies related to the world of telehealth, telemedicine, connected health, however it's being defined on a statewide basis. This is a process that our staff went through over a 6-month period to do a review of all the laws and regulations related to telehealth, and according to a number of different categories ranging from definition to reimbursement to scope of practice, looking at what states provide cross-state licenses. There are a whole number of issues. And you can see what your state is, and as well as what other states are doing in this regard. So this is something we keep up to date, and it's a good, I think, model for other states to utilize as you move forward in looking at reforming your laws related to telehealth. So let's just jump into it. The world of federal and state policies, in my mind, is just like Alice in Wonderland. We're going down on just a little bit of a warning, the wacky world of policies from state to state and the federal government. Unfortunately, the world of technology is moving much quicker. The issues related to using telehealth for the delivery of health care is one in which policymakers have not been able to keep up with. And so as a result, we have a real hodgepodge of laws, regulations across the country. So let's just start with the federal policies. Under the Social Security Act, the definitions for what gets reimbursed under Medicare and what codes get utilized are set in law and then administered by the by HHS through their Center for Medicaid and Medicaid and Medicare. Sorry. And historically, telehealth has not been an area that has received a lot of attention from Medicare. Under the current policies, it will only reimburse for live video consultation. And even though they have made some adjustments in how rural is defined by using the definition of the Office of Rural Health Policy under HRSA, the fact is that only individuals who reside in certain zip codes that are deemed to be rural enough are eligible, and only for live video consultation. So that pretty much eliminates a large sector of the country from being able to take advantage of Medicare to use telehealth under Medicare. Not to mention also that they don't reimburse for remote patient monitoring or for store and forward type services, which are going to become more and more important as we have an aging population. There is a working group at the federal government under HRSA that is composed of 26 agencies, and they just did a thorough analysis and survey of all of the federal agencies throughout the federal government to see who is using telehealth or funding telehealth. And what they discovered is that even within the federal government, there are 7 unique definitions of telehealth, and Store and Forward has, for example, 5 definitions in 4 different agencies, and there are a few agencies that are now actually defining mHealth. So what that tells me and tells other advocates in the field is that we have a long way to go to educate our federal policymakers in taking advantage of virtual care and telehealth for improving access to care and also improving the quality of services that are being provided. Currently, there are a number of bills in Congress that we are tracking on our website, and these are, we try to do a succinct analysis on each one and track where they're going. And it ranges from everything from looking at use of telehealth under the Veterans Administration to issues around cross-state licensing and Medicare. These are the most bills that we've seen since we've been tracking telehealth legislation in Congress, which is a good sign. It means that we have good advocates in the federal government that see the importance of it, and as you can see from the sponsors, we have some bipartisanship in terms of who is actually the lead sponsor on these bills. We don't expect that any of these bills will be passed in this Congress, given the contentious nature of the politics right now, and also the fact that we're going into an election year. But what I would say about this is that having these bills developed and in place, and for the most part, these are all very progressive, forward-looking bills that help to open up the use of telehealth and its various components. That there is a growing sensitivity in the federal government for the use of telehealth, and also a growing voice among telehealth advocates at the state level and at the national level, as well as from industry, and for example, the American Telemedicine Association, which is the strongest advocate on our behalf, to begin to open up these barriers related to telehealth. I'm going to talk about two specific bills that are currently in Congress that I don't believe will pass, but I think they are important in that they get at some of the real heart of the issue that we're dealing with in telehealth. The first is H.R. 5380, is Mike Thompson from California, Greg Harper from Mississippi, and Congressman Welch are sponsoring a bill to eliminate over the next 3 to 4 years this whole notion of having an artificial geographic barrier to the use of telehealth, and adding, for example, not just having the telehealth services be in the four walls of a clinic, but allowing it to be in the home, and importantly, reimbursing for remote patient monitoring and store and forward. These are policies that are supported across the country. The National Rural Health Association has come out strongly in favor of these changes, and unfortunately, we don't have the kind of process right now in Congress to be able to get this in these changes in law. There's only so much that the administration can do to open up these avenues, and without clear direction from Congress to amend the Social Security Act and to provide additional legislative policies, we're really hampered in terms of Medicare in particular, since that's the federal responsibility. There are other federal agencies that have oversight over telehealth and e-health and m-health that you need to be aware of. The Food and Drug Administration is very deeply involved now in looking to see to what extent they're going to be regulating mobile devices and software, and the trend seems to be more hands-off right now, but it is an area that is fast-growing, particularly around the use of mobile devices for behavioral modification and for informational purposes, and linking back to a health information record. The Federal Communications Commission is also an area of importance and of immediate concern. They have just issued a notice of proposed rulemaking related to what they call net neutrality, but essentially keeping the internet open and accessible for a variety of different uses. It's predominantly at this point been focused on the entertainment industry, and we're advocating for ensuring that that the use of the internet remain accessible to all, and that we continue to expand the access to broadband and to high-speed wireless, and that there be priority given to the exchange of health information in that process. It is the lifeblood of any telehealth program, is to be able to ensure that you have proper connectivity and that it's not slowed down for entertainment purposes or for other uses. So that's something that we're going to continue to watch, and we'll have postings on our website. Other federal agencies that we should be concerned about are the Federation of State Medical Boards. It's actually a national nonprofit, but it's a group that advocates on behalf of all the medical boards in the country that set the rules and regulations related to licensing of physicians and surgeons. This is a very hot topic right now. There is a lot of pressure, and there are, in fact, some of the bills that I spoke to earlier are seeking to expand the use of interstate licensure and providing means by which physicians and specialists can provide consultation across state lines. The beauty, of course, of telehealth and virtual health is that the boundary lines of the states, and even countries for that matter, are invisible when it comes to the transmission of this electronic data and for the services being provided. And so rural communities and also, you know, deeply underserved urban areas are never going to have the access to specialists and the kind of services that you would find in more populated areas. But the one thing that we can do is provide those services virtually. And so to the extent that we have shortages of certain specialties, for example, child psychiatry, there is a clear avenue here by which those consultations and diagnostic services can be provided across state lines. Of course, there is strong opposition, and with some good reasons, as to why the state medical boards want to maintain their authority over ensuring protection of patients on a state-by-state basis and to verify that a physician is in good standing. But I think there's a growing movement and a lot of pressure to try to find a compromise. And in fact, the Federation of State Medical Boards has developed a model compact that is currently under consideration to try to ameliorate that problem. But that's another area that we're going to continue to monitor and keep a close eye on. One of the proposals that was in the Thompson bill that was in the draft, which had a lot of support, particularly from the ATA, was to have the license for the purpose of billing and liability at the location of where the physician happens to be. So if you're a specialist in Montana and providing services to someone in Utah, that the license would not have to be where the patient is, but where the actual provider is, and that would open up all kinds of possibilities. So the last piece I'll talk about is the notice of proposed rulemaking. This is an area where CMS, which oversees Medicare, has just issued some rules related to 2 points. They set the billing codes for telehealth and decide which specialties and which kinds of services can be reimbursed. In their new notice of proposed rulemaking, which would take effect in January of 2015, 2 proposals have been put forth that will, in all likelihood, become part of their policies. The first is to open up psychotherapy and psychoanalysis and wellness consultations to just those rural beneficiaries that qualify. This is a big step forward. As many of you know, telemental health is one of the areas that has been well proven and has a long history of being successful. And so to the extent that it can now be reimbursed or will be reimbursed under Medicare is an important step forward. A new billing category that's very intriguing to us and other advocates around the country is the creation of a terminology that's called non-face-to-face chronic care management services. So it specifically does not call it telehealth, but by using the term non-face-to-face, we believe that they would be exempt from the telehealth definition that can include asynchronous and patient monitoring and not have to comply with the actual rule definition. So that's our interpretation, and our consultation with our colleagues in CMS and HRSA seem to indicate that that's the case. So we're going to keep a very close eye on that, and that could be the first real opening in Medicare for reimbursements. So let me move on. I mentioned our state map. The beauty of this map is that when you click onto our website, you can go to with your pointer to any particular state, and it will bring up the telehealth policies according to the 10 or 11 categories that we've established. You can also we have very succinct information related to the law and regulation, and then if you want to go deeper and see the source, then you can click on that particular item, and it'll take you directly to the source in state policy, whether it's in their Medicaid manual or in legislation or in just administrative policy. And as I said, that's going to be updated on a regular basis, and the next update will be in September, just come in a few weeks. So we did an analysis of all the state policies, and as I said before, this is a pretty big mishmash of different kinds of ways of interpreting what telehealth is, how it can be used, and in some ways very aggressive in creating lots of barriers and obstacles to its utilization. Clearly, no two states are alike, no two Medicaid programs are alike, and it also applies to their telehealth policies. A few things I want to highlight here from what we learned from our survey is that the use of telemedicine and telehealth varies from state to state. I think the definition is not as important as the need to provide the kind of umbrella that would allow for reimbursement of the various modalities of telehealth and telemedicine. And so in that regard, 44 states, not surprisingly, reimburse for live video, but only 10 states reimburse for remote patient monitoring, and even less for store and forward. Even though these modalities have solid basis of evidence for their utilization and also provide ways to provide services in a much more efficient way that could save money. Some other things I'll point out in terms of our survey. I won't talk about all of them, but I think it's really important to look at some of the issues that are timely right now. 22 states have special laws that relate to cross-state licensure, so I think that's an important fact. They do have some limitations in terms of the cross-state licensure, but it's surprising to a lot of people that almost half the states in the country allow for some form of telehealth services across state lines. They're also, in their rules and regulations, not only apply to the Medicaid definitions and reimbursement, but there's also language in 21 states that oversees the services of telehealth through private payers and health plans. Some states still have regressive geographic limitations, so to the extent that you can only qualify for reimbursement if you are X amount of miles away or under certain geographic limitations, which again marginalizes telehealth as just something for isolated rural people, when in fact we know it's a service that benefits everybody. And so as you can see, there's also some very interesting new developments in telehealth for areas around home health, speech, language, and pathology. And just here in California, we're very hopeful that the governor will be signing a new bill to create a virtual dental home, an area that I think we're going to see a lot more growth in as we move down the road related to expansion of telehealth beyond medical care. As you can see, there are 192 bills. Again, the most bills that we've seen around the country related to telehealth legislation. And you can track the bills in your own state by going to our website or by contacting us. Not surprisingly, most of those bills relate to changes in reimbursement, but also some very interesting other components such as mental health and expansion of licensing. I wanted to say a few words about remote health monitoring because I think that's an area that's fast growing in the country, and one in particular for rural communities in the Northwest being predominantly rural, a way of keeping people healthy at home and getting out of the four walls of medical care, particularly with healthcare reform. As you can see, there are only 10 states in the country that reimburse remote patient monitoring. In your area, you can see there's Washington, Utah, are the two states that reimburse, as well as Alaska. And this is an area where we hope to see real leadership coming from the states that are providing that, so we can be able to see more reimbursement for this fast-growing area. Just looking at the northwest area, Alaska clearly is the leader in the country when it comes to comprehensive understanding of telehealth and inclusion of both remote patient monitoring and store and forward along with live video. But also, you have Washington and Utah which are some of the few states that reimburse for remote patient monitoring, and Montana is also one of the few states that reimburses for Store and Forward. And there you can see the specific, the devil's always in the details, so you really need to go into your state and look at the conditions under which these reimbursements would take place. I'd like to use Utah as a good example, where they, on the surface, reimburse for remote patient monitoring, but have so many barriers as to what needs to be met to qualify that it's almost impossible or difficult for home health agencies to be able to, and others to be able to get reimbursement. I like this particular one, that a patient has to be eligible, has to travel more than 50 miles on a paved road to obtain in-person services. If it's more than 50 miles, then you qualify. Well, that's kind of an odd way of defining the need for services to be able to keep people healthy at home. Let me see here. So I think, am I ready to pause here for questions? Let me just talk a little bit about the private payer laws. Again, as I mentioned before, there are 22 states that have laws that relate to the private plans reimbursements. This is an area of growing interest. These, again, you need to go to each one of these to be able to see specifically what conditions, because even though they may have some mandates related to private payers, there could be some additional language that would somewhat neutralize the mandate. So it could say things such as subject to the conditions of the health plan, and as an example. So the rules are really, really important to keep an eye on. There are actually only 6 states that provide very clear language about mandating that a private payer to reimburse telehealth services on an equal basis with in-person care, and one of those is in your area in Montana. For those of you who are looking for language for adoption in your particular state, we've looked at all of these, and I think the state of Tennessee is the most recent state to pass this kind of language. And it's very clear. A health insurance carrier shall reimburse for telehealth services under the same reimbursement policies that the benefit plan permits for in-person encounters. I think that's something that we're going to see in other states. We've been in conversations with Kentucky, for example, that's very much interested in adopting similar language. We need to be careful, though, on some of this, though, to ensure that that remote patient monitoring and Store and Forward, which are 2 modalities that are proven to provide greater efficiencies in care without compromising quality, that it could be counterproductive to require equal payment for those kinds of services. So by and large, this language refers to the kinds of services that are provided only through live video. So with that, let me just pause. I'm going to go into talking about where we think some of the future trends are, but this is the quick overview of telehealth policies around the states and federally, and I'd be happy to take a few questions now before I go on.
Mr. Mario, please type them into the question and answer pod. Otherwise, Mario, I guess we're ready to continue moving.
All right. So as questions come up, feel free to put them into the pod, and that way I can be able to see them and be able to respond either as we go or as at the end of the presentation. So the dilemma that we're facing with telehealth policies across the states and at the federal government is the fact that we are now in a pretty dynamic and interesting times when it comes to healthcare reform. Obviously, we have in law now the Affordable Care Act, which is being implemented in various ways across the country. Again, different states taking different approaches. So some states have the federal exchange, other states are running their own exchanges, and to the extent that there is expansion of Medicaid in a lot of states, but not all states. And so that affects how we think about the use of telehealth. But the point that we want to make, and that we're taking more of a closer look at as we're doing our work, is that over time we're going to see healthcare move more to a value-based model and not being fee-for-service. So to the extent that we have this trajectory here of more people, coming onto the Medicaid rolls and getting private insurance through the Affordable Care Act, a continued shortage of primary care and specialists around the country. The population is getting older and sicker, and so to the extent that we have what some people are going to calling the upcoming silver tsunami, particularly in rural areas, the need to adjust and to think about how we deliver health care that adapts to the changes in the lifespan and the needs that will be coming for keeping people healthy longer and at home, and dealing with the multiple chronic conditions that we find in older populations. And then, despite all efforts to reduce costs, in the short term, we continue to see rising healthcare costs, now at $3 trillion a year. So these are factors that I think that are, from the perspective of telehealth, our national dilemma in many ways can be addressed through the use of the expanded use of telehealth. I mean, we all know it can expand access. There's a growing body of evidence, and we've been doing a number of studies to collect the evidence related to improving the quality and outcomes of healthcare services that are delivered virtually. And as I mentioned earlier, there are many modalities now and approaches that actually can save money, either through asynchronous services such as store and forward, remote patient monitoring, but also the fact that we're providing better health care earlier to chronic disease patients can only mean that we're going to be able to save money in the long term in terms of the complications that occur if care is not provided. So I think, if we look at telehealth through the lens of triple aim, I think that helps us get a better understanding as to where telehealth policy and the work that needs to be done to reduce the barriers and expand its utilization and make the case for telehealth. So just recently, we held a one-day forum of national experts around the country, including insurers, providers, academics, and consumer groups, to begin to come together and have a dialogue. And so what we were finding in our work around policy is that each of these sectors has their own perspective as to why or why not telehealth is being utilized, or expansion of telehealth is expanding or not, but they don't really talk to each other and try to find the common ground. So this was our attempt to look at this question through what is now national health policy as part of the healthcare reform, is that our healthcare system should be geared toward obviously improving the health, providing better quality care and access, and ultimately reducing the costs simultaneously. And so that's where we see the changes in healthcare delivery moving more toward the patient-centered medical home and the creation of the ACOs, more approaches to team care, and where the focus is moving away from, it needs to move away from an inefficient system that's driven by the more services you provide, the more fees you can collect, the more profit your organization has. So what do we mean by this going from volume to value? When we pay for results that are measured through quality and efficiency, we will be in a much better position to utilize the limited resources in a more effective way. In a value-based system, we're also looking at how we encourage partnerships. Currently, we live in a world where hospitals and physicians tend to operate independently. In a value-based systems, we will be encouraging more collaboration and more team-based approach to care. Volume-based also is much more focused in inpatient care. That's where the highest volume of cost is. As we move the care down from hospitals to clinics to the home to the community to the workplace, we'll be able to provide much greater continuity of care and better care. And with a real focus on improving health. I mean, that's what it should be all about. And I think that as we look at this through the telehealth lens, there are many ways that the tools offered by telehealth and virtual health, virtual care, will get us from a system that is so focused on taking care of people who are sick to one that's hopefully keeping people healthy. Just a couple of words about how we do our work and what we learned from this forum is that the bottom line of all of our work is based on evidence. And that's what motivates policymakers to a large extent, not only, but to a large extent. And to the extent that there is considerable evidence in the field related to the efficacy of care, but not a lot related to showing its improvement in terms of saving money and efficiency. And so we're really hoping to influence the researchers around the country to begin to think about how you move toward looking at the research in a way that looks at the triple aim and not just specifically at improving the quality of care. The other components that we think are important drivers that need to be addressed and working in tandem with improving the evidence base is to look at working with those who finance care, the major purchasers of care, whether it's public employee unions or private sector. The rapid changes in technology, you're going to be hearing from Garrett in the next webinar, where technology is moving at a very rapid pace. And so the cost associated with the technology, the flexibility in its utilization to be able to get it out to the community is changing dramatically. And that will change. That could be the real change in terms of greater adoption. One area that we have not spent a lot of time thinking about as a policy center, but now are shifting our approach, is around consumer demand. As telehealth becomes better understood by consumers, that it provides better care, that it provides allows people to stay healthy at home, that they could conduct their visits through Skype or have email exchanges with their providers and not have to take time off from work, that you can keep elderly folks healthier at home through remote patient monitoring. We believe all those are critical factors that are going to have a real influence in influencing how we get the private providers, the purchasers, and the public policymakers to get in sync here to get us to scale and make telehealth an integral part of our healthcare delivery system. Some things to look at for the future in terms of how systems are radically going to change, I think, in terms of how we deliver care that are important. We're seeing more and more of how digital communications is affecting just how care is delivered. We have spent considerable amount of money in building brick and mortar hospitals and clinics and skilled nursing homes and other kinds of facilities. But where the real benefit of a lot of the virtual care is going to be is it allows you to be in direct connection wherever you may be. And so to the extent that we're going to be seeing much more of the care that's being provided, particularly primary care and routine follow-up done in that kind of a manner. Thinking about how the moving away from the very narrow perspective of return on investment for technology to long-term research and development has been another factor that we have found has been successful in getting to scale in some of the systems around the country. And then in the interim, as we're moving from this fee-for-service to more value-based work, Providing incentives through either whether it's the carrier providing incentives for greater utilization of telehealth or from the patients themselves, I think are other areas that we're going to begin to see important changes and helping us to move down this pathway much quicker. So just to wrap up here with where we see the world of telehealth go. The only way that this is going to be cooperation from the top to the bottom and across our healthcare systems. That includes the CEO, the CFO, the medical director, as well as the online team of healthcare providers, billers, outreach workers, everyone that is involved in the healthcare delivery system, whether it's the payer, the provider, or the policymaker. We need to be working together to make this, to truly make this work. A couple of quick examples of where we see it is happening. Kaiser Permanente is the largest nonprofit health plan in the country. You have it up in Oregon and Washington, as well as all of California and a few places in the Midwest and the East. They have made a long-term commitment to utilizing their kp.org patient portal for the electronic health record. So their patients, their members all have access to their healthcare information, to their medical records, and have the ability to communicate with their providers on a virtual basis. So a presentation that was made by Kaiser at our forum showed how over the course of the last 6-7 years that they have gone from hardly any visits through virtual visits of either secure email or telephone to almost half of their visits now are done through their portal. And the latest policy changes that I've seen coming out of here is now moving toward the use of secure video through Skype or other means or iPhones to have those conversations and those consultations directly with your provider. And they expect that in the next 2 to 3 years that 75% of all their visits across the country will be done virtually. So the need to actually go to the four walls, to the brick building, is particularly for rural areas. This is going to be, I think, a big, major, and I think positive change for how care is provided. So far, here's how some of the results from their efforts. My Health Manager has allowed them to, I think this is the bottom line for any kind of health plan, is that they were more likely, 2.6 times more likely to remain members of Kaiser as a result of having this form of communication. Also, very concrete examples of evidence of improvement in health outcomes, with improvements in cholesterol, blood pressure, etc., and better health outcomes. And again, bottom line from the patient perspective, 85% of their patients rated either 8 or 9 on a 9-point scale of their satisfaction with the system. So to the extent that we live in a connected society, that the use of smartphones is ubiquitous around the country, even in the most remote areas of our country, that it makes perfect sense that our healthcare would also be an integral part of that, and I think that is the wave of the future. Finally, I'd just like to wrap up with it's not just happening in the big urban areas and on the west and east coast. That here's one of the real examples of change that's happening right in the heartland of our country in St. Louis, with the Sisters of Mercy Health System, where they have built not a hospital per se, but the largest tele-ICU or the largest virtual care center in the country, where they're going to be providing such services as tele-ICU and 75 other services to their members throughout their region. And so truly making that big leap forward in their research and development and in how they deliver care utilizing telehealth. And I'll just wrap up with a quote from Lynn Britton, their president and CEO, that telemedicine lets us provide the best possible care to people where and when they need it, even when patients wouldn't otherwise have access to specialists such as neurologists and pediatric cardiologists. We have pioneered a telehealth plan that no longer limits advanced care because of age, illness, or geography. We can deliver a higher level of care to more people, and that virtual care center is the heart of it, providing care for today while also developing the health care for tomorrow. And I think that's the message here that I want to leave you with is we have to think differently. We have to think about what technology and virtual care is going to allow us to do, and really open up our minds and our creativity to think about how we transform how healthcare is being delivered today, and not be limited by our old thinking that is based on a system that is a fee-for-service in-person care, and not one that's virtual, and will be very different, and I think a real benefit to large rural areas such as the Northwest. So with that, I think I'm coming to the end of my time here, and I want to thank you for your attention, your interest. As I said, you can contact us at any time here at the Center for Connected Health Policy, email me directly or through our website, and our staff here is quick to respond on any questions you may have related to policy, both federal policy as well as your state policies. So again, thank you, and thank you, Bob and Martha, for including me.
Well, Mario, thanks a lot for your presentation, and I'll just add my testimony here that I've had several questions for the center and always gotten quick responses, and their website is absolutely marvelous because it has so much information and it's all up to the minute. So if you have questions for Mario, there's a few minutes left in our time slot. You're welcome to ask them. We also encourage you to take our survey. Martha will see to it that you get good access to it here in a few seconds. And go ahead and type questions in for Mario. I think we can get to them. Otherwise, Mario, I think you were too thorough. There's no questions left.
Well, there's a lot of information presented, and I think a lot for people to think about. And if you don't have questions now, by all means, if something comes to mind, please get in touch with us. We are a national center, and we are virtual, so be happy to help in any way we can.
And then our TRC will be glad to relay questions to the center too, if you feel more comfortable going through the regional group. So you can contact either Mario directly or me, and we'll get you an answer.
All right.
Martha tells us there are questions waiting, and I'm not seeing any. Oh, Mario, click again on your presenter view button. Yeah. There are 3 questions I see.
I see. Okay, there's one from Bruce.
Yes.
What are the differences between telehealth and then I can't see the rest of it. Let's see here.
That's the discussion we've had before, Mario. What's the difference between telehealth and telemedicine?
It really depends on who's asking and for what purpose. Telemedicine has been historically the term that's been used by the field over the last 20 years because it started in medical care. But we have been utilizing telehealth, and I think the field is using the term telehealth now because virtual care can happen in many different ways and many different kinds of services. So I mentioned mental care, behavioral care, social services, dental care, occupational therapy, physical therapy. These are all aspects of health that don't fall under the umbrella specifically of diagnostic care. And so when we think about telehealth, our goal is really the whole continuum from keeping people healthy and health promotion and health education all the way through end-of-life care and ICU care. So it's a term that is utilized more to emphasize the importance of these modalities across the healthcare spectrum. But then again, when it comes down to it, it's what gets reimbursed as well. And so we need to go one step below that to say it's not only telehealth, but it's these modalities of its approach, and it's really a tool that improves care. Let's see. Would you send Pete Carroll says, would you send me the source here for the Utah? Sure, we'll be happy to do that. It's on our 50-state map, but we'll make sure we send that to Bob and give you the specifics on that related to their home care.
Yeah, I'll
Emily
be glad
says,
to
do you?
forward that to her.
Okay, and then Emily says, boy, this is. Do you have any recommendations for successful advocacy of telemedicine parity laws? The example that I gave you from Tennessee, I think, is one. Also, our colleagues in Hawaii also just recently passed one. So I think contacting the various TRCs as to who's involved. But the important thing, I think, is to have the kind of discussions with that are collaborative, and that payers understand the importance of this kind of language, that it's not an attack on them, that it's done through a coalition-based approach to how much of this is done, so that payers, providers, consumers can agree on the importance of this. What we've also seen, like, for example, in Mississippi, where there's some of the more progressive laws, in other states, is that you need a champion. You really need a champion who's willing to, whether it's a state rural health association or whether it's a telehealth coalition, whether it's the university, as it was in Mississippi, that is willing to educate lawmakers about the various particular areas that need change, and parity is certainly one of those that's getting a lot of attention now. Let me see.
And Emily, if you want to contact me directly, I've got a copy of the Montana law, and I've got some links to video testimony before state legislators that might be helpful.
Okay. I think that's all the questions I see on my box.
That's all I'm seeing now, too. I guess we have to click on that presenter view button a couple of times, but I don't see anything else coming up. If there are any more questions, please enter them, and we'll be glad to handle them. And if we don't get to your question now, feel free to contact Mario directly or me, and we'll relay the questions on and get you just as much information as we possibly can. Mario, thank you very much for joining us today.
Well, it's been my pleasure, and thank you for listening. And as I said, we're here to provide whatever answers you may be seeking, and please feel free to contact any of our staff. Thank you.